Assalamualaikum candidates, I am Dr. Nadia discussing on malaria in pregnancy, the diagnosis, assessment and the treatment. So what is malaria? Actually, we should remember that it is an infestation of the uh, plasmodium through the bite of mosquito, that is Anopheles mosquito, and ultimately it enters the circulation and leading to parasitemia, and this in turn leads to generalized infection. So remember that it has further different types, that is Plasmodium vivax, Malaria, ovale and falciparum. Out of these, the most dangerous form is falciparum, which is responsible even to cause the black hemorrhagic fever, and in this case even patient can develop the malignant tertian fever or is having the black colored urine, and because there is hemolysis ongoing, so that is why it is the most dangerous form. Now, malaria is detrimental not only to the female but as well as to the fetus because of the adverse effects, and ultimately, if it is untreated, it can definitely lead to increased morbidity and even the mortality. We must remember that mosquito, that is Anopheles mosquito, bites the surface on the skin and it transmits the protozoa, and these protozoa are being taken to the circulation, and after staying in the liver, then there is erythrocytic form where they invade the erythrocytes. So first there is pre-erythrocyte form, and then later on there is the erythrocytic form, and which in turn leads to onset of the clinical manifestations, that is fever, vomiting, malaise, perspiration or increased sweating, even diarrhea, vomiting, and high grade fever with chills are experienced in the patient. So ultimately, they all interfere with the microcirculatory flow and metabolism of the vital organs inside the body. And I had now the hallmark of the falciparum malaria in pregnancy is parasites which are sequestered in the placenta. Now these parasites ultimately have got the splenic processing and filtration. So rest of the plasmodia, that is vivax, malaria, ovale, they are not sequestered through the spleen, but the falciparum is sequestered in the spleen, and ultimately it results in adverse effects and can even cross the placenta. So the systemic infection comparable to the effects of any severe febrile illness in pregnancy, leading to increased maternal and fetal mortality, miscarriage and stillbirth can be there. Similarly, the parasitism or this in turn can lead to fetal growth restriction, low birth weight, even fetal anemia or maternal anemia, and there is in susceptibility of the fetus to malaria in case of falciparum. Now, what are the causes of falciparum malaria? This is greater morbidity and leading to low birth weight, and also the mortality can be there, and the vivax and rest of these are comparatively termed as the benign forms because they have not got increased risk of mortality. Now, the response to the anti-malarial treatment is multifactorial, but it is associated with the degree of immunity of the patient acquired from the exposure in the childhood and also the background level of drug resistance. So ultimately, higher the resistance, increased the risk of not responding to the drug, and if there is not ultimately and depending on simple, now discussing the few terms. Severe and complicated malaria. The severe signs of malaria are non-specific and other causes must be excluded before assigning the sign symptoms to the malaria. Now, the parasitemia of severe malaria can be less than 2%. Pregnant women with 2% or more parasitized red blood cells are at higher risk of developing severe malaria, and they should be treated with severe malaria protocol. Now, parasitemia is that how much red cells are infested by the parasites. Now, uncomplicated malaria. It is there when there is less than 2% of the parasites in which are actually infecting the red blood cells, and there are no signs of severity. Now, what is congenital malaria? The congenital malaria is not actually the blood-borne malaria or by Anopheles mosquito. Rather, it is acquired in utero and or during the delivery, and not by the bite of the Anopheles mosquito. Now, then next coming towards the clinical and lab findings of severe or complicated malaria in adults. As far as the clinical and laboratory findings of severe and complicated malaria in adults is considered, first we have to uh, keep in mind that patient will be having prostration and, and altered consciousness may be there. There can be acidotic breathing because there are chills, and ultimately there is acidotic breathing. There can be pulmonary edema, and the multiple convulsions can be there. There can be collapse, there can be shock, and even there can be the signs of shock ultimately. And because the manifestations are widespread, and ultimately if there is abnormal bleeding, this can result in disseminated intravascular coagulation, and if the liver function is hampered, it can result in jaundice, and also it can result in hemoglobin urea, so black water fever. Now, severe anemia is when hemoglobin level actually it is less than 7 grams per deciliters. So, because of hemolysis, ongoing hemolysis, there will be hemoglobin level less, and thrombocytopenia will be there. There will be hypoglycemia because liver metabolism is affected, and because of acidosis, the pH is going to be reduced, and the normal, that is normal, is 7.4. Also, there is renal function impairment, and you must remember that the common features in pregnant women with severe or complicated malaria are presented as this, that she is having altered and or disturbed liver functioning. Also, she is having anemia, and there is, because of increased lactic acid, ultimately this in turn leads to acidosis, and also there is hyperparasitemia, that is even more than 2% parasitized red blood cells. What is Ehrlich malaria? That is gram negative septicemia. And also we have to do a lumbar puncture in case to exclude meningitis, because the patient is having high severe headache in this case. Now, what is artemether combination therapy? Actually, artemether combination therapy is a combination of artemether or one of its derivatives with an antimalarial, all antimalarials of a different class. And furthermore, what is resistance? Resistance is the ability of the parasite strain to survive and multiply despite the administration and absorption of a medicine given. So we have to determine that where the resistance lies, which drug is specifically showing resistance to the parasite. So actually we have to give the drug according to the its tolerability, its resistance. Now, how is malaria diagnosed in the pregnancy? So, why is malarial diagnosis difficult? So, there are no specific signs, symptoms, and malarial infection may present with a flu-like illness. So that is why generally we exclude this. And history of travel to the malarial endemic area should be sought in the pregnant, because this is actually showing you a high clinical sign. Now, how is diagnosis being performed? Actually, we go for the thick and thin films. Now, what is thin film? Which is just a thin film of the blood, which is spread on the glass slide, and thick film is where a drop of blood is taken, and we actually see on the microscopy the parasitemia or the parasites which are invaded the red blood cells. Now, symptoms and signs of malaria. As far as symptoms are concerned, I've told you before that generally the patient is having fever, chills, and sweats, headache, muscle pains, nausea, vomiting, and diarrhea may be there. Similarly, the patient might be having cough depending upon the anemia and degree of the disease, and also regarding the signs, because of impaired liver function, there will be jaundice, elevated temperature, increased sweating, perspiration, and misdiagnosis is reported to occur when the leading symptoms are jaundice or respiratory, possibly the GIT symptoms. So we have to be very much confined to the history, any history of travel to the malaria endemic area, and misdiagnosis can be the most common reason cited for the death in malaria. So we have to take the history in detail. And the non-falciparum malaria, the history of travel may be more than 1 year before the onset of the symptoms. And for any woman who has taken the prophylaxis, compliance did not rule out the diagnosis of malaria. So, history of travel to the tropical area and non-specific nature of the symptoms and signs will lead the clinicians to consider investigating the travel-related diagnosis according to the region visited. And furthermore, however, for malarial diagnosis, a blood film is vital. So you all know that actually we perform thick and thin film test. And how should malaria in pregnancy be diagnosed? Microscopic test to identify the species of parasite, so that appropriate anti-malarial should be given. Now the parasites, actually the shape of the parasites must be remembered. And rapid detection test is actually just we take the sample and we assess on the kit, but it may be false negative or false positive, because it is relatively insensitive test. But so the good test is actually the blood film test, where we go for the thick film and the thin film test, where we spread a layer of blood on the last slide, or take a drop and ultimately see the microscopy and sequestration of the RBCs by the parasites. So these are generally the test, and this is showing the rapid reagent test, where we go for the which is actually showing the control in the test line. If the test line is positive according to the control, then it becomes positive, but it is a comparatively insensitive test. So ultimately the rapid reagent testing is comparatively less effective as compared to the blood film test. So the reliable one is the blood film test. Now, in a febrile patient, three negative malarial smears for 12 to 24 hours apart rules out the diagnosis of the malaria. So, the criteria I've told you, and there are occasions for suspicions to remain high, and expert advice should be sought in such circumstances. Now, women who have taken the prophylaxis may have their parasitemia suppressed, because you know that they have taken the prophylaxis. That is why. So we have to count the parasites, and if it is below, and the prophylaxis has been also been given, then definitely we have to consider this patient and accordingly. And furthermore, stop prophylaxis if patient is admitted in hospital. So ultimately, now if she is she may have negative peripheral blood, thick and thin film, but the parasites might be sequestered in the placenta. So that is why now we have to put this patient on the anti-malarial therapy, and we will not give her the prophylactic therapy. So other prognostic factors that should be reported on a peripheral blood smear are the presence of count of mature trophocytes and schizonts of the Plasmodium falciparum, and malaria pigment is more than 5% of the polymorphonuclear leukocytes in the peripheral blood film. So these are actually the tests which you are seeing on the blood film. Is the severity of malaria useful in managing the infection? Now, when women with malaria in pregnancy should have the severity of their condition assessed and documented as an aid to the management. Now, the clinical condition is the most important indicator of severity and should be assessed promptly. Now, the clinical condition, severity of malaria determines the treatment and predicts the case rate. In uncomplicated malaria, we know that fatality rate is low because it is not sequestered in the spleen, it is not crossing the placenta. So ultimately, the complications are more with the falciparum. And in severe malaria, particularly in pregnancy, the fatality rates are high. That is about 15-20% in non-pregnant and 50% in the pregnancy, because there is maternal and placental sequestration both. So ultimately what happens that if there is and then we have to take the history in detail. And the non-malarial the non-falciparum species are rarely fatal, but caution should be still observed in the patient. And once the disease has been classified as severe or complicated malaria, then treatment should be initiated immediately, so that the diagnosis and the treatment is not missed. And how is malarial infection treated during the pregnancy? Treatment area in the pregnancy as an emergency, and admit the patient with uncomplicated malaria to hospital, and pregnant women with severe and complicated malaria to an intensive care unit. And so ultimately, in intravenous artesunate is the treatment of choice in case of falciparum. This is also an MCQ. And use intravenous quinine if artesunate is not available. This is also an MCQ. Now use quinine and clindamycin to treat the uncomplicated falciparum, such as Vivax or mixed falciparum. And further, we have to use chloroquine to treat the Vivax, Ovale, and Malaria. Now the dosage schedule will be shared to you accordingly. And primaquine should not be used in the pregnancy because of effects. And advice should be taken from the physician according to the for the management of the malaria. And do not persist with oral therapy if vomiting is persistent, because the patient definitely will not be having the effect of the medicine. And treat the fever with antibiotics, and the screen women with malaria for anemia and treat them appropriately. And write down a management plan for the follow-up to ensure the detection of the relapse. Now, drug treatment. Delay in the diagnosis and treatment is associated with death from the severe malaria. As I've told you, it's about 50%. So please make sure to understand this table, which is UK treatment guidelines in the pregnancy in case of severe or complicated malaria, in which IV drug is given. And then if it is any species other than falciparum, then the different combination of drug therapies are given. The dosage can be assessed, and furthermore, if falciparum or malaria or uncomplicated malaria is in the patient, and then she can be put on different drug regimes, which are told, which are being shown in the table. And you can acknowledge the table, in which chloroquine or quinine can be given to the patient, which is 600 milligrams followed by 300 milligrams 68 hours later. So these are the different drug schedules which you can easily acknowledge, and accordingly you can follow. And prophylaxis also can be shown, so that if the patient is suspected to have in malaria and travel in high endemic area, then we can give the prophylaxis. So ultimately you should remember that the prescription is limited to the physicians, and similarly treatment in the pregnancy, particularly severe and recurrent malaria, is the best given the experts. And where should the treatment of uncomplicated malaria treatment be given? It is advisable to hospitalize all the women with Plasmodium falciparum, as the clinical condition can deteriorate rapidly, because now here and the RBCs are being affected, and blood films are usually monitored every 24 hours, but clinical deterioration is an indicator for the repeat blood film with how much parasitemia is there. The 7-day course of quinine has significant adverse effect, principally synchronism. Now, what is synchronism? It is actually having tinnitus, headache, nausea, diarrhea, altered auditory acuity, and blurred vision. So these are the effects of quinine. So ultimately, this can lead to non-compliance, and for this reason, hospitalization can be useful, as compliance with each dose of quinine and clindamycin can be observed and may lead to improved cure rates. And furthermore, with the non-falciparum, malaria can be managed as an outpatient care basis, and in this case, we can give the patient quinine, chloroquine can be given, and if there is any risk of vomiting, then definitely we have to manage the plan accordingly. Now, what happens if the patient vomits? Now, vomiting is a symptom of malaria and a known adverse effect of the quinine as well. It is associated with the anti-malarial treatment failure. So ultimately, if the vomiting persists, then we have to give antiemetic to the patient. And there are no studies of their efficacy in the malaria, but metoclopramide is safe in the, although it is category B drug, but it is safe in the pregnancy, so we can give the patient. And ultimately, after giving the antiemetic, we can repeat the dose of the antimalarial. And repeat vomiting after antiemetic is an indication then that we have to give the parenteral therapy to the patient. Thank you.